Mr. Chairman, thank you very much. And first of all, I would like to thank the organizing committee for inviting me here. It's a pleasure and a really joy to visit such a location and such a fantastic venue like you have here. So I've been given the task a little broader than what is in your program to talk about translation research in a wide field. Is it just a modern word, or has it any realistic meaning to thyroid cancer in our clinical everyday work? More than 80% of thyroid cancer is papillary thyroid cancer, and this is a typical type of the young patient, male, 31 years of age, 23 years out since primary treatment with no recurrence. But he still is under surveillance for recurrence, and there is about 20% risk that he will have a recurrence that hopefully may be treatable. And this is one end of the spectrum, very good prognosis compared to other cancers. And this is the other end of the spectrum, the anaplastic thyroid carcinoma, who develops in a few months. And this old lady lived less than six months after the diagnosis. So that makes the thyroid an organ that is very interesting to look for tumorogenic factors because of the variability of the tumors in this organ. I'd like to direct your attention to the enormous increase in incidence of thyroid cancer. That goes from these figures from the United States, and that is true also for many other countries. And you will see that most of the increase is due to the papillary carcinomas. And we will also come back to the fact that almost half of the increase is due to tumors diagnosed less than 1 centimeter in diameter, and almost 90% less than 2 centimeters. And the increase started about 20 years ago and has had no effect on mortality so far, but that may be a little too early to say. But there is an increase, and of small tumors especially. So what I will try to do is to make a status of the present day challenges. Do we diagnose too many so-called cancers? That would not be any problem in reality if they were not shown by ultrasonography or CT or something like an incidentaloma. Do we overtreat these tumors when we find them? Have we got any pre-operative information about the molecular biology of the tumor that could be of any help? Maybe. And we will also touch on the treatment of advanced thyroid cancer disease nowadays. There are an enormous number of small nodules in the thyroid. In the adult population, at least 50% of us have nodules in our thyroid that could be a problem, realistic problem, or just a variation of the normal. So to try to reduce the problem, both qualitatively and quantitatively, it has been suggested that you should not do fine needle aspiration cytology from so-called tumors less than 1 centimeter in diameter, unless for specific reason, like the person has a familial disease history of thyroid cancer, has multiple tumors, signs of aggressive growth like the penetration through the thyroid capsule, and nodal or distant metastasis. And there is also an attempt to rephrase the language, not to make too many cancers. I'll come back to that. So, the European Thyroid Association, the American Thyroid Association, both advise that you should do fine needle aspiration cytology only if there is a suspicious pattern like microcalcification of a certain kind or the personal history that I referred to recently. Americans say it like occasionally there may be nodules less than 1 centimeter that require evaluation. So there's a strong, also a strong medical legal implication of this. So we can have the back free from lawsuits if there should be mistakes in those very small tumors. Some of the leading pathologists of the world also tried to get rid of this problem in a way by rephrasing the name of these small nodules. And Dr. Williams says that tumors less than 1 centimeter should be named papillary tumors, and cancer used only for the case of clinical significance. For example, lymph node positive or distant metastases that may occur in a few cases. Davis and Welch suggested to classify these tumors as normal findings actually and not disturb the patient and the health authorities with a cancer diagnosis. And Dr. Oti foresee number of cancers which may reach endemic proportions in the future if we are not able to select the important nodules, the real cancers, from those of regressive nature. Micropapillary thyroid carcinoma is also a name and a group of disease that has gotten much attention. They are real cancers, but small. And much of the work in translational medicine has been directed to find the low-risk micropapillary thyroid carcinomas, the solitary tumor, unilateral, within the thyroid, no penetration of the capsule, no lymph node metastases, no distant metastases, and that is a group of patients with an excellent prognosis. And then we should use the high-risk determination of those by histology type with an extrathyroidal growth. And much is done to sort the low risk from the high risk. I'll come back to that also for the larger cancers. But they have an excellent prognosis as a group, but there are many cases within these groups that have a serious disease that needs treatment, and that is what we need more sharp weapons to define. And PTC, small papillary carcinomas, is of quantitative importance as well, and socioeconomic proportions. As we know that in France, 2004, Lienhardt found that 43% of operations for thyroid cancers was done for micro-PTC. And in Japan, 22%. And in the United States, 75% of operations for micro-PTC were total thyroidectomies. And that is a major operation for the patient, and it's a major undertaking for the society, actually. In USA, for example, there is nearly 40,000 new papillary thyroid carcinomas per year. So 75% with maybe a large amount of the total thyroidectomies are not strictly necessary to treat the patient or the disease. So it's a major problem in daily undertaking of these tumors. So, on top of that, we find maybe too many cancers, and we treat them like the dangerous cancers. And maybe we do total thyroidectomy too often when we have cancer. And maybe we do radioiodine treatment too often. That means we use radioiodine for thyroid ablation after operation. The golden standard for planning surgery for thyroid cancer today is the high-quality ultrasonographic picture, not of the thyroid only, but of the whole neck, combined with ultrasound directed cytology. But then we know that if we do not have signs for aggressiveness like multifocality, extrathyroidal growth and familial history, radiation exposure to the person earlier, hemithyroidectomy is clearly enough surgery for the small tumors without these serious history. We need more firm information that we can use to sort out these tumors biologically as well. And one of the great discussion areas for when endocrine surgeons meet is what to do with the central compartment lymph nodes. The lymph nodes that are located close to the parathyroids, close to the recurrent nerves, and there is always a weighing to be done between what you can achieve for the patient and what you risk of complications. So there is pretty much agreement that if you find macrometastases in these nodes, you should do a formal central compartment clearance. But should we do a prophylactic clearance? If we do a prophylactic clearance of the central nodes, we will find micrometastases maybe in 20%, but they seem to mean very little for the future of the patients. On the other hand, if you have a recurrence in the central compartment, the risk of complications is very high. And WADA in Japan have a pretty large material concluding that prophylactic central lymph node dissection is not necessary for micro-PTC. But there are some differences of opinion, and we need more firm information of what to do. Also, who should have postoperative radioiodine treatment that needs a total thyroidectomy for the first place? Is postoperative ablation of microscopic thyroid remnants possible or wantable? The newer guidelines, both in Europe and the United States, say that the very low-risk patient, the small unifocal, without metastases, without a dangerous family history, they do not profit from postoperative radioiodine therapy. And if you can define a patient very low risk, there is no reason to add iodine treatment to the primary treatment. The high-risk patients, almost everybody agree that they should have a radioiodine treatment because there are, especially from Masaferi, indications that will help for new recurrence and for survival. In the middle, there is a low-risk group that is somewhat difficult to define, that someone uses postoperative ablation, others do not. Details of the guidelines are familiar to most of you, I guess, but the American and European guidelines have recently been updated and according to the references I've given on the slide. So, do we have new pre-operative information about molecular biology of the tumor? We have known through the years, after histology is finished and after the primary treatment is carried through, information that we should like to have before operation to plan the strategy of the surgery. And now we can hope to see a little results from so-called translational research. In the mid-1990s, we saw the RET mutations, the germline mutations of the RET gene in men too, and that made it possible to do prophylactic thyroidectomies in family mutation carriers. That is a special and well-established effect of basic information. But what has been presented in a lot of articles later years are somatic aberrations, that is, mutations confined to the tumors themselves. A lot of oncogenes, mutations, overexpression of oncogenes has been found, or loss of suppressor genes. The role of non-coding microRNAs are probably important in thyroid cancer. And there are differences in epigenetics, like methylations and things modifying the proteins. But out of all this, there has emerged some information about the BRAF gene mutation, that is the V600E mutation, that is the main mutation of the BRAF gene that we use in the clinic nowadays to a certain extent. This mitogenic pathway is one of many in the cell, of course, and you know it from many other situations as well. But this pathway is active if you have a BRAF mutation, or you can have a RET PTC translocation and a RAS mutation as well in papillary thyroid carcinomas. But this MEK-ERK pathway leads to cell proliferation, less differentiation of the cells, and it stimulates to cancer growth continuously without the need for external ligands to trigger. And in this pathway, the BRAF gene seems to have a very important place. The mutation is present in 30 to 70%, up to 85% of PTCs, papillary thyroid carcinomas. And the mutated BRAF gene correlates to advanced disease, correlates to nodal and distant metastases, absence of tumor capture, extrathyroidal invasion, that is, aggressive subtypes of papillary thyroid carcinoma. That has recently been shown in large materials. And what is maybe even more interesting is that the mutated BRAF expression correlates to the recurrence after treatment, also for stage 1 and 2 tumors. And that is the vast majority, actually, of the papillary thyroid carcinomas. And the expression seems to be important, and that was just confirmed again in large material retrospectively in Pisa, Italy. So, BRAF mutation can be used on fine needle aspirates very easily, actually. And the detection of a somatic BRAF mutation in the fine needle aspirate can give you, with good sensitivity and specificity, important information before you start the operation. It also goes for risk stratification, and it has been shown, again, reviewed recently by Singh in a very good article, that you can use the BRAF mutation to stratify for extensive disease to come, and you have the information preoperatively. Does this have diagnostic consequences? Yes. The BRAF mutation status is used in many departments now. We use it in Bergen somewhat pragmatically, because not to overwhelm the pathologist with work. So we save one sample of the cytology aspirate, and we have it analyzed only if the cytology is follicular neoplasia. As you know, follicular neoplasia can be follicular carcinoma and follicular adenoma. Carcinomas are 25% in our unit, and if we have a follicular neoplasia with a BRAF mutation, we feel pretty sure that this is a follicular type of papillary carcinoma. So we treat it like a papillary carcinoma. And that is because BRAF has not been found in follicular cancers, not been found in follicular adenomas, and it seems to be confined to the papillary carcinomas, and we can sort out a pretty good group with follicular neoplasias without BRAF that maybe will not need a diagnostic operation for histology. And it also has surgical consequences in the way that the correlation between BRAF mutation and the serious run of the disease, recurrence is higher, mortality is lower, makes many centers to look to the BRAF information when they choose the largeness of the thyroid operation. For example, central node dissection, total thyroidectomy, and postoperative radioiodine treatment. The good prognosis in papillary thyroid cancer is, as we know, the possibility to treat recurrences with radioiodine. And I think this is the only disease with proven pulmonary metastases that can be cured by radioiodine. But more and more often we see that the disease changes nature and the cancer cells will not take up iodine anymore. So we have these iodine negative, thyroglobulin positive patients where we have to look for recurrences that could be surgically treatable. There is one note of importance though when it comes to iodine negative. We should remember that if the patients had a iodine contrast CT done less than 2-3 months before we make the diagnosis of iodine negative status, the cells and the iodine uptake must be blocked, can be blocked by the iodine in the CT contrasts, and that lasts for a few months. And what is the unhappy situation during many years? We do not have effective chemotherapy. Chemotherapy of the traditional form is of very little effect in thyroid cancers of all types. Here again, the MEP kinase pathway is the most importantly exploited into the new drugs. Sorafenib and other tyrosine kinase inhibitors have been used now in stage 2 and 3 clinical trials, and they are blocking this pathway, most of the new drugs. Small molecular drugs that acts or aims specifically at the tyrosine or the serine kinases for the BRAF, but it has been shown that the specificity from the cell cultures and from the experiments are not so specific in humans. So there are studies going on for iodine negative cancers, and the inclusion criteria in most of them, both in Europe and the United States, is that the patient must have a measurable metastasis or lesion that can be followed, and the lesion must be increasing in size. That is because many papillary thyroid carcinoma metastases in the lungs can retain the same size for years. So it's meaningful to include them in studies only if they are growing, so we can see any effect. And there are many promising results, promising compared to what we have otherwise And one of the studies for sorafenib with a watershed so-called plot shows that the majority of tumors shrink. That is the ordinate is the maximum of the lesion and a percentage reduction in size. And the yellow columns are for patients who have tried conventional chemotherapy. There are many curves like this, and the effect, there's no complete response, but there is a stabilization of disease and a reduction of disease in many of these studies. But theory is one thing and reality is another thing, and it can be shown that if you block one pathway, for example the MAP kinase pathway, there are many others to take over. That is the reason for the temporary effect of the new medicaments also. And there was a very recent example from a group in I think they are in Korea. They have a new example of an escape route because they found that using sorafenib, the RAF inhibitor sorafenib, there was mitochondrial activities of the BRAF that could not be blocked, like in the cytosolic part of the BRAF effect. And we must expect that there are many escape routes also when it comes to clinical effects. So many of the new small molecular drugs are said to be specific for a certain tyrosine kinase or a serine kinase, but in reality they have more widespread multi-block effects. And there are studies going on the MEP kinase pathway and also the PIK3 and the mTOR pathway that is coming up as one interesting line of trying to block thyroid cancer development. And all these, many of these studies was reviewed by Sherman in United States recently, for those who are interested in more details. But one more point. The International Thyroid Congress in Paris this year, that some of you may have attended, was full of reports on the new drugs for thyroid cancer. And there has never before been so many groups working along this line. So there will be new results to use, but I think it's a pretty long way again till we can treat thyroid cancer recurrences like radioiodine can when it works. I just mentioned as a subject that we we follow in Bergen for the time being. We have had a program called Thyroid Carcinoma, Molecular and Clinical Aspects. It's a wide title to have fundings from the authorities. And it started with a tissue bank of fresh frozen sample tissues combined with paired non-tumor tissues many years ago. This is just an example. We became interested in this because there was a clear overexpression of a certain protein that was not defined at that time, about 2005, that we found in aggressive thyroid papillary carcinomas. And that it was, this is normal thyroid tissue from the same patient with a tumor tissue that with hybridization technique is full of a so-called N-terminal acetyltransferase. That's an enzyme that was not described in man before, but is known from the yeast. So we try to find the function and if it relates to cancer, because we found that differences in. And the enzyme is part of a complex sitting on the ribosome and making not epigenetic, oh yes, it is epigenetic changes to the proteins, but the changes are made while the protein is made on the ribosome. So this was a strong acetylator of proteins, and acetylation make the protein work in another way than without. And we found that if we blocked this enzyme with small interfering RNAs, we found that several types of proteins changed their effect. And there was growth inhibition, cell cycle arrest, apoptose-like cell death, and frank apoptosis. And that is that by knockdown or by partial knockdown of this enzyme, the cells this is in the cell cultures, stopped to grow. The cancerous cells stopped to grow to a large extent. And that was a new observation. And we also found that in different cell cultures, if this enzyme was blocked, the growth rate was much less than without knockdown. And these are different cell types: carcinomas, follicular carcinomas, anaplastic. And the effect, the slowing effect on the differentiation and proliferation of cells was cell type specific, and one drug worked in one place and one other drug in another cell culture. So again, examples of the diversity that we might have a chance to play on and use. And since then, this enzyme complex, N-acetyl transferase complex, has been found active in gastric cancer, in colorectal cancer, breast cancer, neuroblastomas, and recently found to be involved in the 5-FU effects in colon carcinomas. So we cooperate with the American group designing molecules. I will not go into that, but they are the specific molecules to block the amino acids in the protein proper. And during the last years, we found 4 enzyme complexes of the same type. Like for the tyrosine kinase inhibitors, we see that they have a little different effects. That is apoptosis. This is another way of cell proliferation stop, cell cycle arrest, apoptosis, and apoptosis sensitization. Meaning that if we can find specific blockers for these type of enzymes, that might be effective in vivo. But so this is a long run, and this is just an example of how translational research goes on. Start with a protein clearly upregulated in aggressive tumors. Not only using this as a factor, we think it's important to try to find the function behind the difference. And there was the enzyme on the ribosome, and we found the inhibition of various cells by various drugs. There was a large work done together with American University on the specificity of the enzymes, what amino acids could be, were the ligands. Inhibitor design, we are now in the phase of trying new inhibitors that becomes more and more effective, but then we have to go to mouse models, and it's a long jump to patient treatment. So this may or may not lead to important things, but it illustrates the long road to go when you want to exploit findings in the lab, or findings stemming from the patients and taken to the lab. At last, I would like to say a few words about the roles of the surgeon in translational research, because it is clearly obvious that we will need more information, much more than has been gathered up till now. The surgeon is close to the patients and close to the tumor and non-tumor tissue at the operation table. And that is a very important position that the surgeon should draw consequences from. The surgeon should also be present in the lab to represent the clinic. I mean, present by mind, or not always in person, but cooperate closely with the basic scientists. And it is a goal to find the best basic scientists, of course, to cooperate with. And hopefully the surgeon might someday be able to bring the knowledge to the next patient on the line. A few words about what is very important if we are going to come further to close and true information. The impact on the tissue we take from the tumor and the normal tissue at an operation is very dependent on how we handle it. And that has not been much studied earlier, but there was a recent article now about breast cancer, but principally you have the same problems in thyroid and all other cancers. In only 11 patients, but they found that 461 genes, and some of them very relevant for cancer, were modulated as a function of delayed freezing. And it was not enough to have so-called good quality RNA samples, because the level of expression could be completely different. And it was elegantly phrased by a pathologist in Annals of Surgery recently, that say that the new powerful technologies pose risks for wrong answers with great speed unless the analytes and specimens are of high quality. And the surgeons and the pathologists alike contribute significantly to the final molecular composition and the integrity of the resected tissue. And that we should bear in mind. And if we are going to initiate research and the surgeon to fulfill his role as a gatekeeper to tissue sampling, the surgeon must learn the techniques, or at least the language of molecular biology, so we can cooperate, clinicians and basic scientists. And the surgeon must have a key responsibility for the pre-analytical aspects of samples. How many seconds, how many minutes does it take from it's out of the patient until it's deep frozen in nitrogen, for example? And how long is the ischemia time in the patient before the organ is taken out? So the surgeon, together with pathologists, together with technicians, must make strict routines and logistics for the very simple handling of specimen in the operating theater. And it should be taken care of and deep frozen in the operating room, and not after 10 or 20 or 30 minutes in the department of pathology. In that way, we can make tissue banks for cooperation. If we are going to cooperate, we must see that we have the same way of handling specimens, and if not, we can go astray and get results that seems important but are wrong. So, has any translation research led to any conclusions? I think this progression has been slower than we thought 15 years ago, but we have been aware of the extreme complexity of the matter. There are not so many genes as we thought when they found the human genome composition of about 25,000 genes, but there is a vast array of protein variants like acetylations, like epigenetics, and there are many pathways that may take over when one fails, and so forth. So there are some important implementations into diagnostics, treatment and risk factors, and that is especially the role of BRAF. And For surgeons that has made a little difference. So nothing very much has happened, but it seems reasonable to be optimistic, I think. And that is the final words. And the people who have done most of the studies I've talked about, especially Thomas Arnesen, who is the main person in the acetylase enzyme history. And in Bergen we have a close connection between the clinic, the hospital. Just outside of this picture we have the basic scientists almost in the same building, so we have a campus that should be good for cooperation. And we have had many visitors that we have been glad to host in Bergen from Turkey, and you are all welcome to visit our venue.